infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Now, intestinal infection with the bacterium Clostridium difficile is the most frequent healthcare-linked infection in the U.S. Each year, it afflicts about 500,000 Americans, costing tens of thousands of deaths and taxing the healthcare system by about $5 billion. In a new study published in the Annals of Internal Medicine, researchers say that multiple recurring C. difficile infections are increasing. Joining me now is the lead author, James Lewis, MD. Dr. Lewis is a professor of medicine in the Gastroenterology Division and a senior scholar in the Center for Clinical Epidemiology and Biostatistics at the Perelman School of Medicine at the University of Pennsylvania. Dr. Lewis has been on the faculty of Penn for about 20 years. Dr. Lewis, welcome to the show, sir.
Well, thank you for inviting me.
Yes, sir. Very interesting research. And before we get into your research, can you give the audience an overview of Clostridium difficile infection and multiple recurring C. difficile infections?
Sure. So this is a form of an infectious diarrheal illness that's caused by the bacteria Clostridium difficile. Historically, this type of infection occurred most commonly in patients who were hospitalized for other reasons and were treated with antibiotics. For example, patients treated with antibiotics around the time of surgery or to treat pneumonia. It's believed that the antibiotics disrupt the normal bacteria that colonize the human colon, allowing C. diff to flourish and cause a diarrheal illness that we refer to as C. diff colitis. Fortunately, most C. diff infections can be cured with a single course of antibiotics. However, some C. diff infections recur shortly after patients complete the course of antibiotics. Typically, this is treated with a second course of antibiotics. But when this happens a third or a fourth time, we refer to this as multiply recurrent C. diff infection.
So we'll go to the study. And how did you and your colleagues perform this study?
We used data from Optum Insight Cliniformatics database, which includes claims data, meaning insurance data, for nearly 40 million Americans from throughout the United States. And we took this existing claims data and we studied people with their insurance claims data between the years 2001 and 2012. We excluded patients who had a diagnosis of a C. diff infection or who had undergone fecal microbiota transplantation in the first 6 months of the data. And then from everybody else, we examined the rates of C. diff infection and multiply recurrent C. diff infections over time during the years 2001 to 2012. And from this group, we identified multiply recurrent C. diff infection based on those patients who'd received 3 courses of antibiotics to treat C. diff infection, and each course had to be separated by at least 14 days, but no more than 56 days.
Okay, so what were your findings?
So the main findings were that during the period from 2001 to 2012, the annual incidence or the annual rate of C. diff infection and so of C. diff infection went up by about 43% during that time period. But multiply recurrent C. diff infection went up by about 190% during that same time period. And importantly, this increase in multiply recurrent C. diff infection was independent of the typical risk factors that we think about for C. diff infection. And so I guess I want to emphasize that even though the multiply recurrent C. diff infection proportionally increased much more than C. diff infection, still most cases of C. diff infection didn't become multiply recurrent C. diff infection. So I want to make the distinction that even though proportionally there was a much bigger increase in multiply recurrent C. diff infection, fortunately most C. diff infection still gets better with 1 or 2 courses of antibiotics.
Gotcha. Now, do you know or can you speculate why are we seeing such an increase in the multiply recurrent C. diff infections?
Well, that's a really important question. The most concerning hypothesis is that we've seen perhaps a change in the biology of C. diff into a more resistant strains. And I'm using that term resistant pretty loosely here because, in all honesty, many people are what we refer to as asymptomatic carriers of C. diff, meaning you can have C. diff living in your colon without even causing you a diarrheal illness.
Right.
Importantly, our study was not able to examine the strain types that infected these patients. We did our study using insurance claims data, not actual samples to actually identify what sort of strain caused the infection. I also want to, I think our research was very important, but I think it's important also to identify the limitations. And another important limitation of our study is that we examined treatment patterns that looked like multiply recurrent C. diff infections. However, some of the cases could have been reinfected with the same strain or reinfected with a different strain of C. diff, or even have had a different type of infection, or even had a non-infectious cause for their diarrhea, such as, for example, some people after they have C. diff infection go on to get post-infectious irritable bowel syndrome that was mimicking multiply recurrent C. diff. And so there needs to be certainly more research to really drill down further into this, because there's a lot of possible reasons that could explain the patterns that we saw.
So were you surprised by the results?
I would say I was a bit surprised. I mean, it was our hypothesis going in that this might be the case, and in part we were interested in this because of the enormous interest in fecal microbiota transplant today, and that's sort of what prompted our interest in this. But I didn't anticipate that the differences were going to be as large as what we saw.
Sure. And you mentioned fecal microbiota transplantation, FMTs. Is this the answer? Is this how we get a handle on this problem?
I don't think that fecal microbiota transplantation is the long-term answer. It is a very, very effective therapy for multiply recurrent C. diff infection. And in the short term, it seems to be both safe and effective. However, we really don't have a great understanding of the long-term safety of this technology. And we know that the human gut microbiota is a metabolically active community that you can almost think of it as an organ, or at least part of our bowel, if you will. And so exchanging one person's microbiota for another person's could have meaningful long-term health consequences, but this has never really been adequately studied. And so I don't think doing wholesale fecal microbiota transplantation is going to be the long-term solution. I think that there will be other solutions. For example, one of those solutions is to get a better understanding of, what are the critical organisms that need to be transplanted to resolve C. diff infections, and then to develop what you could think of as reagent-grade fecal microbiota transplantation that's grown up in a laboratory and transplant just those specific microorganisms so that you know exactly what you're putting into the patient.
Oh, interesting. Dr. Lewis, is there anything else I didn't cover that you think is important to mention?
So I guess this is my public service pitch. So my public service pitch is that for those patients out there who happen to have multiply recurrent C. diff infection and need a fecal microbiota transplantation, I encourage you to ask your physician if they are participating in the American Gastroenterological Association's fecal microbiota transplantation registry. This is a prospective registry which is designed to help us understand the long-term consequences of undergoing fecal microbiota transplantation, both the beneficial and the potentially theoretically harmful consequences of undergoing transplantation. And I think it's really important that we gather this information going forward. So if you happen to be in this situation where you need a transplantation, ask your doctor if he or she is participating in this so that you could contribute your data to this really important research enterprise.
Well, very good. Well, thank you, Dr. Jim Lewis, for your time and expertise, sir. I appreciate it.
Thanks so much for inviting me to be here today.
You bet.